So I'm going to present a different perspective to what you just heard from Dr. Budoff. I'm a clinician, and I use cardiovascular imaging for prevention in my patients. So here is a patient I saw literally the day before yesterday, 45-year-old, who came to me because she had an abnormal echo finding. Her only symptom is fatigue, and she has a history of hypertension. She's on losartan and torsemide, and that's because she has a higher filling pressures on echo. Never smoked, no known diabetes, no first-degree family relative with premature coronary artery disease. She had mantle radiation for Hodgkin's lymphoma 20 years ago, and that's the reason that she developed valvular heart disease, including moderate mitral regurgitation with some increased PA pressures. She had a normal coronary angiogram 5 years ago. Her BMI is 35. Her blood pressure is listed here. Her lipid profile that was available to me when she came to see me is listed here. And her hemoglobin A1C, which had also been done before she came to see me, is 5.9. Her upper cutoff is 5.8. So when I put her numbers in, including that the fact that she's a hypertensive on medication, I get a pool cohort risk equation for 1%. So for a 45-year-old woman, a pool cohort equation would still give it a 1% risk. It actually is less than 1%. It's hard to kind of determine from that. So what should I do? Let's assume that I don't belong to Shape Society. I'm just a normal physician who sees patients with valvular heart disease in my clinic. Well, I would probably think she's low risk and does not meet criteria for initiating statins. Or, say, well, she's short-term risk, but she's a high long-term risk, and therefore perhaps best to start her on statin. Or if a person like me sees her, I would want to get, or maybe somebody else in this group sees her, we would probably like to gather more information. Now she's 45. She's already suffering from radiation-induced heart disease, and I totally understand that calcium scanning carries a very low radiation dose. What would you do? Would you do coronary calcium on her? Or would you do a carotid IMT on her? Or would you do a stress test on her?
Tasneem, I think one of the important clinical features that you described is prior radiation exposure.
Right.
Which can cause accelerated vascular disease even without calcification.
Right.
So,
and that's the reason she had a coronary angiogram for some non-specific symptoms, which was negative. So, given my interest and given maybe our enhanced sensitivity to the topic, I actually did carotid ultrasound on her in my clinic, in my office, which takes 10 minutes to do. And she had plaques in her bulb, and her coronary, her CIMT was more than 75th centile for age, race, and gender bilaterally. So here is a woman who, before I did this test, was obviously focused on her heart disease from radiation. And here we are finding the subclinical vascular disease, as well as in the setting of hemoglobin A1C, which she never knew was high because this was the first time that was tested. So that made it much easier for me to modify her medication, but more importantly, to talk to her about statins and the need that she should go on those. So that's like the springboard for my discussion on carotid IMT and plaque assessment. I'm actually going to touch more on the conventional studies that have been done in carotid IMT and plaque. And Henrique is going to talk more about the more recent developments in plaque, including three-dimensional plaque imaging that he's been involved with the HRP project. So unlike coronary calcium, which is always abnormal, CIMT is a normal structure. We have a carotid artery which has a wall called intermediate thickness, which is what we measure by ultrasound. So that fact alone will imply that if you were to use CIMT alone as a marker of atherosclerosis, you will be wrong for a substantial number of times because it's a normal structure. Whereas when you were identify calcium, because it's an abnormal finding, anything more than 0 will imply abnormality. And that is a fundamental way of looking at it, that one should look at the literature behind CIMT and why CIMT has been less robust than coronary calcium scanning in risk prediction and risk stratification. And what we need to do to go beyond that. So here is the here is the intermediate layer that we measure. Now, atherosclerosis tends to form in the bulb and the internal carotid artery. Why? Because that's where the turbulence occurs. And if you again were to focus just on the far wall of the common carotid artery, there is even a higher likelihood that you will not identify atherosclerosis because you're kind of avoiding seeing atherosclerosis if you were to just measure this one area, which is the far wall of the common carotid artery. And the reason this has been measured over earlier studies is because it is the most reproducible area to measure carotid IMT, which is such a tiny number and really requires a lot of precision in order to be reliable. The plaques, the plaques are really what CAP is, and if you were to look at plaque as opposed to IMT, now you're looking at true disease and atherosclerosis. It does not imply that CIMT does not look at disease, it does, but it also can identify a normal layer in somebody who may have atherosclerosis in the bulb or the internal carotid artery. And then we have this conventional definition of plaque, which is a structure that is greater than 50% of the surrounding IMT value or an absolute cutoff point of 1.5 millimeter. So unlike coronary calcium, which is a very objective assessment based on a Gashson score anywhere from 0 to any amount of calcium, the assessment of plaque traditionally has been first, what is plaque? People have struggled with that definition. And then secondly, if they identify a plaque, most of the studies have just limited themselves to plaque yes or plaque no. It's as if saying coronary calcium yes, coronary calcium no. And obviously if you were to take that approach, you can again understand why there has been a limitation in the predictive value of even plaque. So this is the various grades, these are the various grades of abnormality you can expect to see if you were to use carotid ultrasound to identify subclinical atherosclerosis. So here is again, IMT is dependent on age, gender, and race, and so keeping that into account, for a 57-year-old female, a mean IMT of 0.612 at the far wall of common carotid would be normal, whereas for a similar age male, a mean IMT of over 1 millimeter would be abnormal. So this is normal IMT, abnormal IMT. Now we progress to the real atherosclerotic disease, where you now have a focal plaque. There would be no disagreement on this plaque. But notice in this patient, you have a completely normal IMT. So if you were to use IMT as a surrogate here to predict cardiovascular events, you would say this patient is low risk, but this plaque tells you this patient does not have low risk. And so there are different ways, the phenotypes of atherosclerosis that one has to keep in mind. And then finally, the significant burden of a stenotic plaque, which obviously confers a high disease. And I'm showing you this so that you can understand how different studies have been done and why we have conflicting results. Now, some people have not only just looked at IMT and plaque, IMT with or without plaque in the carotid system, they've also gone on to look at the femoral bifurcation and done the same kind of evaluation, IMT alone or IMT and plaque. Now, IMT has been shown by studies that it actually represents your risk factor burden throughout your development years, including your childhood and adulthood age. So in this study of about 500 patients, the patients had 3 measurements of their risk markers, including lipids and blood pressure measurement and BMI. And then the IMT was measured at age group, this is between 25 to 37 years of age. And they found that the IMT at this age they have not formed plaque yet, is really representative in multivariate modeling of the burden of LDL cholesterol that they were exposed to during their childhood and adulthood. So in other words, if you were to use the CIMT alone, you can actually use it in young adults to reflect their their exposure to risk factors during their growing years. In addition, this is a cross-sectional study in about 500 patients. So in patients who have heterozygous familial hypercholesterolemia versus normal controls, you can see that IMT is able to detect that burden of risk factor, which is hypercholesterolemia in this case, quite nicely across the spectrum of 10 years to 80 years of age, and actually shows divergence earlier on at about 20 years of age. So this is a test that actually can be applied to a younger population, let alone later age years. Now this is a study in about 500 men, all were 58 years old, this is just the nature of their enrollment, who had various degrees of insulin resistance and BMI, who underwent only plaque imaging, no IMT, of the bilateral carotids and one femoral side, so three vascular beds. And they found that whether you had no plaque in any of the two beds or only one artery had a plaque, 2 versus 3, the cumulative incidence of cardiovascular events over the 10-year follow-up went up significantly based on the presence or absence of plaque and the number of beds that had the plaque. And when compared to systolic blood pressure and triglycerides, plaque in the femoral artery conferred almost a 2-fold risk, in the carotid artery about the same, but when you added the 2 vascular beds, your ability to predict heart cardiovascular events went up about 2.6-fold. Now, we all know about this study where they went back and looked at the ERIC data, and by this time they had 15-year follow-up in about 13,000 patients. And ERIC, which originally reported just the CIMT data, inclusive of plaque or exclusive of plaque, this study only looked at whether adding plaque actually added any incremental information. Again, here all we are doing is saying plaque yes, plaque no. We are not quantifying plaque burden, we are not saying how many numbers, we are not saying how large, we are not looking at plaque area. Just adding the plaque information alone, just a categorical yes or no, was able to reclassify 23% of subjects to the appropriate risk category. They had significant events, about 500 patients had heart events during this follow-up. Now so the ERIC study, as we all know, is between 45 to 65 years of age. This is the cardiovascular health study, which is in more than 65 years of age. And again, depending on which quintile, now the difference between this study and ERIC is ERIC looked at all the different segments of the carotid artery, but they had a high missing measurement rate for internal carotid artery. This was done in the late 80s, early 90s, so the technology was not as well developed. This one looked at the IMT of the common carotid artery, but also the internal carotid artery. They just looked at the IMT. It could have plaque in it, it could have not have plaque in it. And this was able to discriminate the power of future cardiovascular event in this more older population of about 5,000, 4,500 people. So if you were in the bottom quintile versus the 5th quintile, the events were about 300% higher in those who belong to the highest quintile of carotid IMT. So we are kind of moving on from childhood to adulthood to now some older age groups and seeing the predictive nature of this test, which is kind of, with all its limitations, the way it has been done. Now we are going on to people who are 80 plus years of age, and this is again data from cardiovascular health study, and here we have the data for coronary artery calcium for men and women, and at the bottom is the IMT data for both men and women, and the prediction for cardiovascular disease, MI, and stroke. You can see that as you move up the quartiles of IMT, there is ability to predict cardiovascular events. The more abnormal you are, the higher the event rate. Here are the quartiles of coronary calcium scoring, and similar ability to differentiate low risk versus high risk by both tests. In both genders, the difference was that CIMT was able to predict stroke better than coronary calcium scanning was, but it appears that in this study, at least, the predictive power of both tests in this older cohort, 80 plus years of age, was comparable. This is a study that was done a few years ago where they looked at the prevalence of calcification on a whole body coronary calcium scanning. Sorry, not coronary, the whole body CT. And they found that roughly 50% of women aged less than 50 years of age will have no calcium anywhere in the body, and 30% of men less than 50 years of age will have no calcium anywhere in the body. And the areas they looked at are listed here. So coronary, aortoiliac, carotid, and so on, and the various combinations of these different beds. On the other hand, as you grow older, the burden of calcium increases, becoming about 70% in women more than 70 and about 80% in men more than 70 years of age. Now, we have talked about the fact that a significant number, 50% of population, has a coronary calcium score of 0. So if you were to take the example of the patient that I mentioned, had she not, the fact that she had radiation to her chest increases the likelihood that she may be found to have coronary calcification. But if you were to see a 45-year-old woman otherwise, who's 45 years of age, it's very likely that you're not going to see calcification of the coronary arteries yet. And we know that these women are high risk. We know that the pooled cohort equation, which has just can't come out, but the Framingham risk has done a miserable job of identifying women at high risk. And so if you were to take patients who have coronary calcium score of 0 in a large population here, you can see that IMT is able to differentiate, is able to identify different disease burdens even in this population with a coronary calcium score of 0. And similar to this large data set that I shared with you from Folsom study, this is our own study where we did a very carefully performed comparison in predominantly a low-risk population who came to Cedars-Sinai and had both coronary calcium and carotid ultrasound done for the purpose of primary screening. And in patients who had Framingham risk of less than 10% at the time, which is about 100 patients, again, 40% have, 60% had coronary calcium of 0. 40% had some disease. But if you were to look at carotid ultrasound, the prevalence of disease in this low-risk population was higher than would be identified by calcification. And we have relatively younger population. I think our mean age is about 58 years. Obviously, if your Framingham risk is higher, then across the board, if you were to look at CAC of more than 0, or CIMT of more than 75th centile, Plaque alone, or a combined CIMT of more than 75th and Plaque, about 85–90% of people have disease. But more disease was found by ultrasound than by coronary calcification in this relatively younger cohort. And interestingly, amongst the patients with coronary calcium of 0, almost half had plaque on ultrasound. And this is not just our finding, this is a finding again from other studies as well that I'm just going to share with you very briefly. We actually found a relationship so that as your CAC score went up, your plaque score went up, or percentage of people who had plaque. But we did not find this relationship with CIMT. So as your CAC went up, we did not find that the CIMT also went up. So again, when you compare apples to apples, which is coronary artery calcium with plaque, you're going to find a better correlation. But when you compare coronary artery calcium with IMT, again, because of the limitations and the pathophysiology and just the nature of the wall thickness, you are not going to find a good correlation. This is a study that is just going to come out in Jays from Mayo Clinic, where people address this question in this female population who are 58 years of age. There are about 90 female population whose Framingham risk score is about 2%. Their mean LDL cholesterol is about 138. And they looked at what was the coronary calcium score in women who were found to have plaque or high-risk CIMT scan. And again, about 60% of them had 0 calcium score, and then about 30% and about 5% had higher calcium scores. And then, similar to prior studies that I just showed you, these are the CIMT percentiles in women who had calcium score of 0. So here we're looking at plaque or IMT. Here we're just looking at IMT. So we have a significant number of women who have atherosclerosis identified by ultrasound when their coronary calcium score was 0. Now I'm just going to shift the topic a little bit, and this is a slide that we're also familiar with. Carotid IMT and coronary calcium scan were the two tests we had recommended in our 2006 statement. What about femoral vascular bed. Is there data that adding femoral vascular bed assessment actually improves your risk prediction? The two beds are very similar. They are both located in exposed areas which are relatively easy to image. They both have the same anatomy. They both have a bulb with bifurcation into two segments, and the bulb is conducive to the development of atherosclerosis because of the nature. So this is a study done many years ago by Balsero et al. From Italy, where they took 10,000 people and followed them for 10 years and graded their atherosclerosis burden by ultrasound of both the carotid and the femoral arteries. And they graded them from 1 to 4 depending on the same morphology that I shared with you earlier on. So normal IMT, abnormal IMT, focal plaque, non-stenotic and stenotic plaque. And then they looked at their percent cardiovascular events, which is MI and stroke and cardiovascular death. They found that patients who had class 1 anatomy had only 0.1% event rate, and that was 80% of the population. The 20% of population who had a majority of events, about 99% of events, had between grade 2 to grade 4 morphology, and the majority of events occurred in people who had grade 3 to 4 morphologies. In addition, they found that scanning both the carotid and the femoral segments actually identified 14% more events independent of each other. So you will identify more events if you were to go to more vascular beds. And the event rate prediction was similar for all types of CAD.
So I want to break the silence here. In our problem with, you said relatively easy. Is it really easy to do femoral ultrasound and be able to identify plaque and not see a lot of other stuff?
I think if you're doing femoral ultrasound, you will have to just confine yourself to plaque assessment and not go for IMT measurement.
Mm-hmm. Even plaque is just, I have very limited experience. It's not easy.
Well, I have talked to my colleague Costley from New York, who uses femoral ultrasound routinely. And according to him, the time it takes to assess femoral ultrasound is identical to the time it takes to do the carotid ultrasound.
Yeah, well, you guys, Henrik,
Yeah, okay,
our comment, is that possible?
So in a typical vascular surgical clinic, you will actually be looking at 60% people with lower limb disease. And we scan every single person of them, and it's a 10-minute thing. And we also look for hemodynamics, which is obviously the most important thing, not for risk stratification. But again, as I'm going to be talking about, you can do exactly the same here that we suggest to do on the carotids. Do this cross-sectional sweep, which takes 10 seconds. And then you look at it afterwards. And I would think that the bilateral is less than 10 minutes if you just look for plaque and don't bother about measuring.
Bilateral femoral?
Yep. Bilateral femoral in 10 minutes? Yeah.
10 minutes?
Yep.
Yes. Well, it takes me about 7 minutes to do bilateral carotids.
That's it.
Yeah, I mean,
with results. I'm talking about with results,
Sure.
with the graph and the plotting and everything.
Sure.
So 10 minutes for femoral bilateral is not unreasonable.
So the only bad news is that people have to take off the pants. And the other bad news is, of course, if it's a big, if it's BMI plus 35, it may be more challenging.
More so I can basically just back up what you're saying from our work in PESA and what we're doing in New York now. We have 3D plaque and almost all our studies that represent some snippets of, and it's exactly that. But it's basically doubling the carotid time.
Right.
The only additional discomfort and or time consuming thing is the patch.
Disrobing, yes.
okay, yes.
Do you mind commenting a little bit on the people who are discordant? You had shown the concordance rate between the IMT and the CAT results. And is there anything we should be thinking about the underlying pathobiology of patients who are in the quadrants that are discordant? So someone with the high CAT or low IMT.
So it is far more true that if you have zero calcium, you're going to find atherosclerosis by ultrasound. The reverse is also true, that there are some patients who will not have carotid plaque, will have some coronary calcification, but the percent people who are missed as having atherosclerosis by carotid ultrasound and have a cap of more than 0 is much lower than vice versa. And this is to do with the pathogenesis of atherosclerosis that I showed you by the whole body CT. The atherosclerosis in carotids develops much later than it develops in the aortoiliac areas and the femoral areas, which is why if you were to evaluate those areas as well, you are probably going to have most of the patients who have atherosclerosis, because coronary calcification and aortoiliac calcification develop together. So if you have CAC in your coronaries, you have atherosclerosis in your aortoiliac junction. And so therefore, the chances of picking that up by femoral ultrasound are far higher than picking them up by carotids.
And have there been studies on people who have the IMT findings but have very low CAC scores, suggesting that they're just different diseases?
Yes, there are.
And I'm trying to think from a genetics perspective. I haven't seen that teased out as.
I think one of the risk factors that's more closely related to IMT and carotid plaque hypertension, much stronger
Right.
related
Yes,
to
yes.
hypertension and age than it is for coronary diseases. So clearly the mechanisms that lead to carotid plaque development and coronary plaque are not necessarily identical.
Yeah.
Age contributes to both,
Age
but
is very-
hypertension leads to
For
median
carotid
hypertrophy.
more age is a very strong determinant of IMT and plaque, as is hypertension.
I can comment here. There are a few studies that are suggesting that we have sort of heterogeneity of vascular bed in the same population to shear stress. We all know shear stress is the background. Has to be there. But so different zip codes of susceptibility exist. I was thinking, you said carotid is the later stage?
Correct.
So aorta is predominantly the first, and then iliac and femoral and so on. If you are able to do a protocol like what Henrik is going to show, the HRP and PACES that you're doing it in 20 minutes, you scan four beds, 2 femorals and 2 carotid. You're saying you will have a greater chance of collecting pretty much everybody,
Correct.
even those who have zero coronary calcium.
Yeah.
Right. But you need to have a goal of why you would want to do that.
Yeah.
Like include all is, I can do that. I don't need to scan everybody and say everybody's got plaque. I don't understand the goal of finding that 100% of people have atherosclerosis, because it's not going to help you in the study design at all. You're now increasing the number of people enrolled from 40%, let's say, with calcium to 100% by doing full body vascular. From back to 100%, I'm going to use Sanjay's algorithm of treat all. You don't want everybody included.
But that's why I was bringing up, are there
You don't want
different-
it. That's not what our goal is here. More, it's useless.
Yeah,
It
well, we'll
becomes
get there.
useless
We'll
to
get
have everybody being
Let's just
identified
look
as
at the
positive.
data, because we are trying to, so the difference, the way this ultrasound field has lagged is that we don't have a burden of atherosclerosis that we could say, you know what, okay, well, a 70-year-old person has a 1.5 millimeter plaque. Well, is that really abnormal? In my opinion, no. But if a 30-year-old has the same plaque, of course it's abnormal. What we have not been able to do in ultrasound is to develop those cut points, like you have 100 of CAC, and 300 of CAC, and 400 of CAC, and that's what we need to do. So the purpose of evaluating 2 vascular beds is to come up with an atherosclerosis plaque burden that Enrique is going to talk about, which has been compared against corresponding values in CAC, because that's what we have had a significant deficit in the area of ultrasound.
Yeah, Matt, you can look at it like your coronary calcium. You go through 30 slices to cover the entire heart. She's saying this is like equivalent of that. Currently we are doing only 15 slices, just top. We're going to do the remaining, and then we come up with a scoring method, and the burden, total burden, will define. You can still come up with 40% of those people to be treated. It depends on your cutoff point and where you put your cutoff point.
Right, but the intermediate step has not been done yet. In other words, the long-term risk of that cohort.
Yes, it has.
I know it's been done a little bit in the one publication that we've seen from bioimage, and I've worked on 10 other abstracts on bioimage, but we don't have the robustness of multi-center studies and multiple population-based studies to use a new algorithm. So just understand the limitations. If we're trying to design a trial to say we want to use a new untested, relatively untested method, that poses yet a whole giant layer of...
That's wrong. I think what we're saying is that when you're using the very well-tested CACS method, why don't we add what's going to be maybe the future, and it's going to give us other opportunities in the future that CACS is not going to give us. That's what we're saying.
Okay, but I'm just saying, and I'm not against it, I'm just saying that to use it as an entry criteria, you have a lot of intermediate steps that would need to be done in science before we'd be ready to absorb that into a trial. That's all. I'm not.
Okay, but what about Balsero's data? Balsero's data is 10, 15 years old, and they used a very simple method. They did not use the 3D cut points. They just said normal IMT, abnormal IMT, non-stenotic plaque, and stenotic plaque, and they were able to identify the 99.5% events that occurred in the 20% of that 10,000 cohort, which is very similar to the CAT data that you have, and that's 2D. Just saying plaque yes and plaque no. They're not quantifying. So that's we don't have to go with data that has not been really validated. So there's only one study. I agree. And again, other question would be how reproduce. I mean, how many people can actually do it? To who would that technology be available? This is a technology that's available in every center that can do vascular ultrasound. So it's something that has actually been done many years ago, which is the Balsero study I just showed you. I'm actually going to kind of cut short and just show you a couple of things that I think are important. These were some more slides on multiple vascular beds. But I just want to share with you some of the work that I have done where we have actually shown that you can train a workforce to perform this carotid IMT. And let me show you. So here is the plaque screen. Can you pull up the data from the zip drive? I just want to show you the...
I need you to just imagine that.
No, they will not imagine because they don't do it every day in their practice, so they have to see it. Yes. Because one of the issues is that when you do a short axis sweep, that the resolution of ultrasound is not good, that you can miss plaques. I just want to show you a sweep that I trained my first year resident. Just go to date modify, right there, and then there will be a couple again. And there's no movies in there. Okay, I can pull this up later, but I just wanted to show you that the technology is here and is currently available. You can, a novice with a 5-day of training, and I have the training. Yeah, just maybe this one is fine here. I'm sorry, the patient identifier might show because the movie is not playing in my talk. But here is a resident doing a short axis sweep of the carotid artery. So here is the vein, the artery, the thyroid tissues around it. Here's the common carotid artery, and they're moving up the neck. And then here is the bifurcation, and here is the internal carotid artery, here is the external carotid artery, and then you can go up. If you can show the next one, then I'll shut up, and then I'll pass it on to somebody else. No, I think you just showed this. If you can go to BB, yeah, that one. Yes. So here is another patient. This is a trial that we did. We took 50-year-olds who presented, people with less than 50 who presented with acute MI. Actually, this is not the one. But again, just to show you that we are able to see the entire vascular bed, and this was done already like 3-4 years ago, and a novice can be trained to do this. So if you move away from IMT and just focus on plaque, and how many segments have plaque, what's the plaque thickness, we actually can come close to characterizing the plaque burden if we include another vascular bed besides carotid.
Thank you, Tasneem. Let's give a round of applause.